Good afternoon and welcome to Beyond Telehealth and Telemedicine is Medicine. My name is Dr. Lisa Finkelstein and I'm here with my friend Mark Painter. And Mark is going to introduce himself and tell us about PRS, what he does and what his company is all about. So hi, Mark.
Hi, great to see you. Thanks for having me today. So I've been involved in reimbursement and coding and all things related to practice management for far too long, or more than I care to admit. I still enjoy it very
Me
much. Yeah. So PRS was started back in 1989. We have provided coding and reimbursement information to a number of specialties throughout the course. We teach seminars. We have agreements with 9 different national specialty organizations to provide information to physicians. We have a revenue cycle management arm, so we can actually see that what we're teaching works or doesn't as we go through all of this, as we know the payers vary and how they do things. And then we have a consulting division that works not only with physician groups across the country and different specialties, but we also work with a lot of the biomedical device and pharmaceutical companies, helping them try and figure out how they're going to take their new products and introduce them to the market in a way that actually makes sense to physicians and the business aspect of their lives as well.
I'm going to read to you, because I have it written down, how you start your new podcast, because I love this. I think Scott reads it.
Yes.
We help urologists and staff achieve peak economic and practice efficiency so there is time and energy to focus on patient care and a happy life.
Yes,
That's such a Painter thing to say.
It is. Well, we early on took they've got the triple aim, and we think they very much missed in the triple aim. It should be a quadruple aim. The fourth leg of that should be provider management and happiness in the whole process. Because without your good managers who really are happy and healthy, you don't have a system that works. So,
right.
Yeah.
So understanding reimbursement is so important, and that's why thank you for doing this. And I'm passionate about telehealth, so this is about reimbursement for telehealth, and that's what we're going to focus on today. So let me look at my questions because I want to stay on point.
Okay.
A couple of years ago, I was tasked to form a telehealth department and show our administration and our physicians how telemedicine works. Lisa, they said, you do it, you show us how it's done. One of the biggest barriers that I came across were physicians that didn't believe that we were getting paid for these types of visits. So this is pre-COVID. And we had those restrictions in place, and we'll talk about that. With the originating site, I live in Wyoming, so it's rural. So we were within and compliant within those rules. Took a lot of effort, but I actually had to show them, okay, look, guys and girls, here's our charges. These are the codes and the modifiers. We are getting paid. Now, jump ahead to COVID, same thing. There are a lot of myths and misconceptions with physicians that still believe that we are not getting paid for telehealth visits and will not be getting paid for telehealth visits. So can you give us your opinion about that?
Sure. So first, I'll say, like you, I started talking about telehealth a couple of years ago. We had some obvious indications from Medicare, even in the whole and their rule changes, where they started adding codes and expanding what they would allow for in the telehealth space. And you could see that that tool, meaning telehealth, that the tool of telehealth to help solve some of their issues was going to be an area they were going to expand um, moving forward. I mean, the obvious issue of access that has been talked about for so long for multiple specialties has been a difficult problem to solve for Medicare. So they did start making some inroads there. Well, when COVID hit and everybody was locked down, CMS actually moved very quickly to open up what they would pay for so that patients could still get care and remain safe during the pandemic. Um, they basically, by rule, created an opening to allow for physicians to bill for new patient visits and established patient visits, and even went further with some of the Category 2 codes to adding things to the list that would not normally be included for telehealth, because there was a patient benefit from both caring for the patient, but also keeping the patient safe. And that all began last year in March. And that list and the adjustments they've made throughout have been really focused on expanding what is covered. And it took them a couple weeks to figure out what to do, because the changes that they've been making to make telehealth a permanent part of healthcare had a new place of service modifier that was introduced, the 02, and they realized that the 02 modifier was geared to pay on the on the facility rate, and that during COVID they wanted to make sure that everybody was paid the non-facility rate, which is what you would typically be paid in a face-to-face encounter. So they went back and resurrected an old modifier, the 95 modifier, and said, use place of service 11, regardless, which is office, regardless of where the patient is, and actually, regardless of where the physician is.
I was going to bring that up.
Yeah. To when you're providing a telehealth service, and add the 95 modifier, and we'll pay you as if you've done it in person. They opened it up to new patients. So you didn't have to have an established relationship with the patient to provide these services. And everybody's been getting paid from Medicare since that time. The private payers were not that far behind. And they have been expanding telehealth. And actually, there was in the final rule of 2018, and then again confirmed in 2019, that allowed Medicare Advantage plans to expand telehealth far beyond what Medicare did.
Before COVID. Yeah.
Pre-COVID. And
right.
So we actually saw, and one of the things we started talking about in 2019 in preparing everybody for 2020, the Medicare Advantage plans were very actively promoting the use of telehealth for specifically chronic diseases. And the focus was primarily on primary care physicians, where they were actually going out and talking to their primary care physicians and saying, hey, look, we're going to expand the benefits here for telehealth. Some were going as far as saying that we're gonna allow you to get reimbursed like you are in the office. Others essentially opened up office visits for patients with chronic conditions, so that they were going to be paid regardless of COVID to do office visits via telehealth. So there was a lot of groundwork that had been laid. They were trying to move that forward, and then of course, when everybody got shut down, it just blew up. I mean, we went from, I think it was somewhere around 1,400 visits a week to, I think it was like 2 million in a month in the first part of COVID. So, and I can tell you that, through our revenue cycle management company, we have all of our physicians all across the country that are being paid by Medicare and a lot of your private payers right now. In fact, most of them.
And Medicaid,
And,
big payers of telehealth.
and Medicaid will stay there, by the way.
Right. Medicaid will stay there.
Yes, because and actually, there's great stories early on about how Georgia leveraged their Medicaid and telehealth. If you ever want to look at some of the back story there, they had a couple of nurses that figured out how to leverage their prenatal care through the Medicaid program. It was very impressive how they worked around and through the system, or maybe just worked the system to get telehealth everywhere. So it was there, and now it's here. And patients, the reaction from patients has been resoundingly positive. There are definitely patients that still can't figure out video or still don't have the bandwidth to do a full audio visual connect. And CMS realized that early on and opened up the telephone only services. And they're seeing that advantage as well with some of the changes they made this year, adding to the CTBS on all of this. So
what does that mean? The CT, is that a communication code? What is CTBS?
CTBS is Communication Technology Based Services.
Okay.
So CMS has to come up with an acronym for
alphabet soup.
Yes, it is. So,
yeah.
And that was growing prior to COVID as well, and now it's making further advances.
Well, physicians have always felt put upon because we, at the end of our day, have to get on the phone and do all these callbacks to patients and not get reimbursed for any of those types of interactions. And so, but that is kind of, as a telemedicine champion, I was always advocating, even pre-COVID, for video because CMS was paying for the video component almost on parity with the face-to-face. The audio was severely lagging, where we were getting paid like $12 or some ridiculous amount. And the physician said, forget it, Lisa, it's not worth my time. And then, as they say, the so-called, hit the fan. And how did that, CMS has been unbelievably nimble in reacting to the outcry of patients not being able to get on video. But what's happened, in my opinion, is that the physicians that have been reluctant to embrace fully telemedicine fall back to the telephone as telemedicine, and that's what they call a telemedicine visit. And the reality is what, Mark, that is probably going to go away?
So Medicare's already let us know in the final rule for 2021 that once the public health emergency is over with, the telephone only codes for ongoing care, typically like a regular visit, is not going to be paid. Those are the 99441, 42, and 43, which paid like the 212, 213, and 214. So those are not going to be covered moving forward. Now, as I keep kind of circling back, the CTBS, which are more management tools, if you will, than visit tools, I think, for the office, those have been expanded. And the ability for PT and OT and so to do those types of things has been expanded even beyond the pandemic and the public health emergency.
Right.
So they're still exploring it. They're still trying to leverage things, but they're working around some specific restrictions in Medicare law. I don't think in the end there is as much animosity towards the phone only as the rules would project. But there is at least some that's there, and the way they write their rules, you'd think it was only for a last minute of emergencies, but there's more exploration there to be done, I think.
So just to give people a little bit of what's happening right this second is that the public health emergency was extended through April, another 90 days. And most of us think that that will be extended again into July. And then we don't know what's going to happen. So we're still in the clear as far as using these new telehealth rules.
Yes. Yep. We're set until right now. The expiration date is April 21st.
Okay.
With that 90-day extension, and so through April 21st, new patient visits, phone calls, established patient visits, being able to do the work from your house, all of that's still good to go.
Okay. There's a lot of confusion also as to what the terms mean. They use the terms virtual check-in and an e-visit. And physicians are always asking, they're using these terms interchangeably. They use them for telehealth visits. They just don't know how to use them correctly because it's clear when you read it and dig into that, which is what you do for a living. But physicians don't, right? They're like, oh, I can do an e-visit. Oh, I can do a virtual check-in. And they don't understand what that means. So
Yeah.
can you explain a little bit more?
Sure. So basically, e-visits or telehealth, for the most part, with the exception of phone calls right now, are actual visits. I would put those in the telehealth category, right? So those are straight back and forth. Virtual visits, actually, no, I should probably
Virtual check-in, yeah.
yeah. Let's start with virtual check-in. So virtual check-ins were really created around CTBS, right? So those are technology that doesn't include visual for the most part. They are primarily phone, or they could be done exchanges through portals, and some of the technology with secure email. It all has to be HIPAA compliant, of course, as they do. But virtual check-ins have to be initiated by the patient. They can't have been the result of or a continuation of an encounter, and they can't lead immediately to another encounter. So they're essentially standalone requests by the patient. And examples that we see all the time are patients that may have a urinary tract infection that has been treated, it goes away, then maybe they come back again with a call saying, hey doc, I think I got another one. Do you think you can call me in a prescription? And the physician checks the chart. There's still medical legal risk associated with all of that. And you'd say, fine, we're going to call that in. And if that works, great. If not, come see me. That would absolutely hit the definition of a virtual check-in.
So in that respect, physicians again say, but Lisa, how much am I going to get reimbursed for that, snippet of my time, which takes time and effort to get into the chart? What does that reimburse?
So first of all, I'm going to say more than zero.
Okay.
So I mean, that's the one, you're going to do that anyway. It's not going to make you wealthy on most of those. The original e-visit codes are $15 or $12 depending on what actually comes into play, and then they've added a new one now that's about $30 for the reimbursement. Of course, that we're using medical national numbers, so they vary from place to place. But it's and so ultimately, can you build a practice on e-visits? No. And part of that's because you got to have an established relationship with the patient after the public health emergency ends. But it is at least something that's there. And I think the other thing that physicians tend to focus on is it's only $12. On the other side, well, I would say the other side of that equation is you took care of that in a few minutes. And now you haven't taken up a slot in your office that could go to a new patient or a patient that needs to be treated for something, and has tests that need to be run and all the other things that are there. So, focusing solely on that top line reimbursement, um, instead of considering this an adjunct tool to help your practice be much more organized and ultimately run more efficiently. um, that's the bigger benefit in these check-in codes, and the continuity of care you can give to your patient, because when's your next available appointment is that next question. And if it's 3 to 6 weeks out, you really haven't done your patients any good service. So a lot of people were just saying, fine, renew it, not a big deal, we'll wait and see you somewhere down the road. It's absolutely an efficient way to grab and do those connections with your patient to keep them on the right track and make sure that they get the care that they need.
So what you're saying is it's not always about reimbursement and how much money. There's a bigger picture here. There's a philosophy that you've always inspired practices, a different way of looking at keeping that patient engaged, keeping them coming back, and telehealth now is a way to do that. And I love that philosophy. So you had some great examples of let's say that prostate cancer patient that you want to counsel them and talk to them about all the different options are available or support. Expand on that philosophy using telehealth.
Okay. So, it's kind of maybe a little bit of an offshoot to say that it's actually qualified telehealth on
Right.
Medicare's definition. But, when you look and I hear this over and over again, that, all right, I'm going in and I'm going to spend some time with a patient who's facing a choice of multiple different treatments for a disease process, prostate cancer, incontinence, overactive bladder. There's a number of them. And so every physician I run into has a relatively canned and extremely repetitive story that they tell the patients every single time, explaining we can do this or we can do that or we can do this. Here's the drawbacks to this. Here's the advantages to this. That is a repetitive process that they go through each and every time. This is where video and outreach in the tele world, we'll call it telemedicine, because you're providing teaching and education to people.
Telehealth.
And I think overall telehealth, not in the Medicare definition because that gets paid for, but in the overall reach to your patients, to give them the information that they need, that education that is so important, and then bring the patient in for a decision-making visit instead of having to do a time-based visit. For example, if I've always told you and everyone else, if you look at the medical decision-making and the guidelines for evaluation and management coding, and with the new guidelines, you can bill based on time for any one of your encounters. But I will tell you that you can do a level 4 visit in 5 to 10 minutes. If you bill it based on time, it's 40, right? So if you can take that level 4 medical decision-making visit and take that in 10 minutes, because you've already provided the education and the feedback to the patient in a non-paid video or even a group educational session and an outreach program, now that they're all used to Zoom, so that they can ask, so you can do 50 patients or 100 patients in just asking their questions at the same time. You've now really bumped your office efficiency and the revenue. And if you look at it in a dollar per hour side of the equation, it is much more efficient to do things that way.
Unfortunately, physicians are not used to thinking that way. They're very used to thinking about, I need to bring that patient in and I need to examine them. Let's go over the physical exam component of it when it comes to telehealth. One of the drawbacks that I hear again and again and again from physicians, and it took me a long time to make that leap as a osteopathic physician, number one, who's trained with my fingers, and number two, I'm a urologist. And so, we examine our patients all the time, but if we're honest with ourselves, most of the time it's just a lot of consultative and education. And so the physicians that say, but Lisa, I can't examine the patient. Telehealth, and also with the changes in 2021, how important is that physical exam when it comes to having a higher level visit and getting reimbursed and documentation?
Sure. So first up, when the public health emergency came in, one of Medicare's immediate moves was to say history and physical examination are not going to count in selection of your level of visit. We're going to base it solely on time or medical decision making. And that statement was actually reflective, or and to a certain degree, an acceleration of the new 2021 evaluation and management guidelines. So they had the foundation of the 2021 guidelines that were already printed by the AMA, and they just basically pre-adopted them partially. So we're already in 2021. So at this point in time, now we don't even need the special rule that allows for that, but history and physical exam and the documentation that is required is only what is medically appropriate for that encounter. So essentially what you can get from the patient as far as the history that they can give via telehealth call, if you have the ability with video to do some physical observation and it makes a difference to the visit, then include that. But the reality is, if based on what you know about the patient over that telehealth visit allows you to make a treatment decision, then all you need to document is what you gleaned and how you applied it. Is really what it boils down to.
This is going to take a huge Herculean leap for those of us who have been trained in the early 90s through 2000s to change, the fear of God that's been placed in us in how we do coding, which is, how you and I first met back in the early 90s with, going through all this stuff.
Yeah.
And it's very, very difficult to convince physicians to change. There's a couple of examples. One that I've told on these interviews, a pediatrician who is a sports medicine doctor who had a mom and her baby that had a dislocated elbow, nursemaid's elbow, that traditionally come into the office. I will reduce the baby's elbow. It's not an emergency, but it's urgent. Well, mom said, I'm not bringing my baby in. And he talked her through the maneuver, how to put that elbow back in place. And that changed his thinking. The same light bulb went off for me when I was talking to a mom in her mid-30s with 3 kids. She works. And she said to me, you know what? This is pre-COVID, way pre-COVID. Lisa, if I never have to bring my kid in to see a doctor and take off work, shoot. Sorry, I thought I turned everything off.
Yeah, the dangers of technology.
Oh my God, I turned everything off and still went through. Sorry, guys. But she said if I never have to bring my kid into the doctor's office and have to miss work, take the kids out. And that was it for me, because I was of the belief that a telehealth visit can only happen with once you establish a relationship with the patient. And COVID has totally flipped it on its head. I also want to just say one thing to our viewers and our physicians out there who think that they're not getting paid, is that in our hospital system, since March, that we have billed over a couple of $1 million of visits and have gotten reimbursed well over $1 million. And that the statistics for CMS are now that there have been over 1 billion telehealth visits that have happened.
Yeah.
So the physicians that think that this is going away are just not seeing what's happening.
Yeah, I agree. I mean, the number of patients that I've heard from, and the number of, we'll say, children, that talk to us about what their parents are doing and everything. And I mean, their responses across the board is, "Yeah, I'm not going to the doc ever again. As long as I can do telehealth, I'm doing it." It's when you think about the cost on their standpoint, it is, it's not just the copay, it's the travel, it's the taking off work or getting the kids babysat. I mean, there's
Economically, it doesn't make right. Economically, telehealth makes sense
it does.
for
And
everyone.
yeah,
I have another question. I have a couple questions. My next thing is remote patient monitoring, or RPM. There's also myths and misconceptions about physicians and nurse practitioners, nurses who are actually doing RPM, that think that they are not getting paid for this service, that it is they're doing it because it makes sense, it's great for the patient, but they think that they're not able to get paid for that. And that also has changed significantly.
yes, it has, and it's not done changing. I can tell you that right now. So, the RPM codes, of which there are several, have different elements to them. Like there's a part for training the patient how to use remote patient monitoring equipment. There's a code for that and a payment for that. There's a code for the lease of the equipment or the loaning of the patient for the equipment that is paid for. And then there are the codes that talk about the interaction and management based on the remote patient monitoring, that this year CMS clarified that they're 30-day codes. So the range is 30 days, and there has to be analysis of the data at least 16 of the 30 days. And that can come in various formats and forms. And then the time spent by the nursing staff helping them understand what the tools are and how to use them, as well as any instructions that they give to those patients, is covered, whether it's done by the staff or by the physician on some of the remote sides. Now, there are other codes that are set and obviously reimburse higher that deal with the physician actually dispensing advice based on remote patient monitoring. So, and then of course you've got your chronic care management as kind of an adjunct to that falls into some of those categories. So there's a great deal of expansion that's already been done. There are holes still in place in that system. Like, what about the remote patient monitoring that's less than 16 days that Medicare is still trying to do?
Yeah. Like
So
watching patients that, maybe just for 2 weeks that are post-COVID.
yes,
Yeah. There's a question that comes up all the time with these new RPM codes where, not everybody is going to have a connected device, Bluetooth, that can be uploaded into a dashboard. it doesn't really make sense that Medicare wouldn't pay for RPM if a patient had to manually put in their data. Can you clarify that?
So there does have to be some monitoring or information that is provided. It doesn't have to be real time. It can be, you know, like the patient docks it and loads it up every once in a while. And the information needs to be collected over time. So you've got a little bit of leeway there in that it doesn't have to be real-time Bluetooth. All of a sudden, it's picking things up. It can come in chunks, but it does have to be something that is a monitoring of the patient rather than a patient saying, "I peed today," or something like that. So there does have to be something on the back end that actually is a monitoring device. But how often the data is uploaded is not as specific, and it doesn't have to be real time.
Okay.
It can be.
So there's some flexibility, and a lot of people think that there's not this flexibility, and it's not that clear when you read it.
Yeah.
So, okay. I have two more topics. We are way over time. I apologize. Are you okay to keep going?
Yep, I definitely.
Okay.
I'm always long-winded, so I always add a little extra time.
Which is great that I have you here. So I want to ask away. So another passion of mine is remote telehealth teaching or supervision. So there's a couple ways, for our primary care doctors who are teaching medical students, they can't always be in that nursing home or in the facility, that things are going to be heading in the direction of, using a video type of telehealth where they could be sitting in their office, the medical students could be in the nursing home, and there could be reimbursement from that model. Have you heard anything about that?
Yeah, so they extended actually in the final rule that audio-visual monitoring is now part of the permanent payment structure. So even post-pandemic, if you can establish a video audio link, and this from the other side is a potential of being able to monitor staff in the office from the hospital. There's a number of different ways that can be done, or from the home if the patient or the physician had COVID and had to tunnel in and supervise his office. And then because of that remote audiovisual connect, it's billed as if it were face-to-face.
So let's use a specific example of that. So I'm at home or I'm in my office and there's a nurse who can't get a catheter in, and we get on camera using their telehealth platform, and I instruct the nurse on how to place that catheter. How would that be coded or reimbursed?
Okay, so you do have to use place of service. So we'll assume they're in home. So you basically, the place of service for that visit has to be wherever the patient is.
Well, let's say they're in the hospital.
So the hospital is a different issue because we got the incident 2 rules in place, because that's where the audio-visual monitoring is in place. So they are opening up what we can do with other people's hands, if you will.
Yeah, exactly.
But that one's not as clear as if it were to have been you're at the hospital and the patient's at the office. And then that one's easy. That one's you would bill as if you were there.
Because that's an originating site, you're saying.
Correct. Or if you were even at home and the patient was in the office, because those are incident 2 services. Because the issue being that because the nurse actually doesn't work for you, that the efforts of that individual are not typically allowed under the incident to rules. So the audio visual monitoring and allowing for billing for those is more about your own staff and your own people than it is about others. So that one's a little more difficult to run through. But that's, as we ran through that audio visual supervision number and the way it all worked and what was permanently added. Now, still during COVID, you've got the ability to bill that as if you were there. But the issue is different after COVID.
So you're using this term incident 2. What does that mean?
So that would be if you were in the office and a nurse was putting catheters in, it would actually be billed as if you did it.
Right.
Even though the nurse did it. That's incident to the physician.
Oh, I see.
So that's how that all fits into play.
I had asked questions about these categories 1, 2, and 3. That's another area of confusion. Can you explain that, what's temporary, what is permanent? What do those categories mean?
Okay, so category 1 are permanently telehealth, and so even after the public health emergency ends, then those can be provided. Now we're under restrictions after the public health emergency ends that the patient has to be in a medically approved facility and a health professional shortage area. So there's going to be limitations there, but the codes that are on that list include office visits, hospital visits, ER visits, and it really, I think most physicians should be able to take advantage of some of those codes without a doubt. Now, then the category 2 data or the category 2 codes are codes that aren't traditionally like a telehealth visit, but they do provide patient benefit. So those codes are on the telehealth list during the public health emergency. And so there are things like radiation treatment management, for example, is on the category 2 list. So it's covered during the public health emergency, but after it ends, it will no longer fall into telehealth coverage.
Okay.
Right. And then the category 3 codes, and this is where emergency departments visits fall. So they mirror category 1 in that, yes, it's a patient physician encounter type of thing. Discharges from the observation or the hospital department, these are all in the category 3 area, which essentially Medicare said, yeah, they really do almost fit category 1, but we're not sure. So we're going to cover them during the public health emergency, and we're going to continue to cover them until the end of the year in which the public health emergency ends. And then we're going to think about adding them to the list long term. So,
okay, clear as mud. And so when the next statement is that it will take an act of Congress to pass laws to make some of these restrictions go away, what does that mean?
So right now by law, Medicare can't cover telehealth for patients in their home. The public health emergency allowed the secretary to override that. And that's why things are covered right now for patients to get care out of their home. The CTBS codes and some of those Medicare has figured out how to shoehorn, if you will, services into that without putting them into the telehealth care category, which is why one of the reasons they came up with CTBS. So they've basically said these are fill-ins, or they basically kind of redefined them to allow them to be paid for on a permanent basis. So that's why they're they fit into that CTBS category. So it will take Congress actually changing the law that bars Medicare from covering telehealth in a patient's home. And I don't know if you're ready for the pontification or anything that's out there, but I the patient support and the wave of support for telehealth and the number of people who have experienced telehealth and positively experienced telehealth really in my opinion is kind of an unstoppable wave. And so the will is there, the desire is there, and so the only thing that stops an unstoppable wave is the politics that are on the hill, because it does have to go through Congress. So now you've got at least coming up a consistent party within the two houses and at the presidency, and whether the pluses and minuses of all of that can be debated on many different levels, but the one thing it does allow is for action, and given that this kind of unstoppable wave is there, and the demand from the patients and from physicians, and now you have kind of removed that last barrier potentially. I would say that this year is very, very possible that we will see that barrier removed.
So you covered my last question, was take out your crystal ball, Mark, which is what the doctors asked me, and give me your, what's going to happen in the future, because you think, I'm assuming that you think that telemedicine is here to stay.
I do.
What would your message be for the physicians that are still hesitant to make an investment into telemedicine in their practice?
So I guess I would say a couple of different things. So number one, telehealth isn't or shouldn't be considered as a substitute or an exclusive remedy for patient care. It is an additional part of your armamentarium to supply patients with the care that they need. But it is something that you are going to have to invest in to use. As I look at the future and what's there, I would encourage physicians to really take a look at their practice as a whole. It's the utility and the ability to reach out to patients and to provide them the support that they need, to guide them, especially patients on chronic care issues and with chronic problems, to guide them through their disease process to a reasonable result. Telehealth is an exceptional tool for that. That doesn't mean you're not going to see them in person. It means that you're going to be able to supplement what you provide them, and then again, looking at your practice as a whole, open up your practice for new patients that need tests, patients that are on their way to procedures, and take out some of those, for lack of a better term, howdy visits.
Low risk.
Yeah, those things that can
hold your hand, kind of. Yeah.
Yeah, I mean, patients have now. There are a lot of patients that showed up in physicians' offices because that was their only social interaction.
That hug.
So there's still going to be some. So it's not about an either or an exclusivity package. It's an inclusion. It's an extension of what you can provide your patients to really improve their care and their overall experience. and it needs to be invested in and looked at as one more tool in the toolbox.
The toolbox. I couldn't agree more, Mark, because the reason why I got into telemedicine was when Snowmageddon would hit in December in Jackson Hole, Wyoming, and I could not make it to Pinedale, Wyoming, and the entire clinic would be shut down. And then the patients would have to wait until I could get there again, when not every patient needed my hands. And so I was on board 10 years ago for all of those reasons. And the silver lining of the virus is that it did what we thought would be 10 years in 10 minutes.
Yes. It gave everybody the tools and then forced them into the experience.
Because healthcare needed a good shakeup, right, Mark?
It's, as my dad used to say, most people don't change unless there's a significant emotional event. This was definitely a significant emotional event for everyone.
Tell your dad I said hi.
I will definitely do that.
Well, I'm going to keep listening to your podcast. Mark, I'm going to end the broadcast, but hang on, okay?
Okay.
Okay. Thanks again.
Thank you.